Okay, team, are we ready to start?
We are.
Okay, wonderful. So hi, everybody. My name is Mary Jane Burke, the Marin County Superintendent of Schools. We're really happy to have you join us this afternoon. So you can see what we're trying to do is make sure that we're making any and all available information ready for you in as close to real time as possible. And given the way things are moving so quickly, you'll be hearing things that in just a few minutes that is right hot off the press, if you will. So as a reminder, this session will be recorded and the recording will be available within 24 hours. In addition, this will be translated in Spanish. So I'm going to ask Michelle Drake to go ahead and provide our Spanish speakers information on how do they get to the translation.
Thank you, Mary Jane. Bienvenidos. Este webinar se transmite simultáneamente en español. Haga clic en el botón de interpretación del idioma que aparece en su pantalla si desea escuchar esto en español. Muchas gracias a Marta Bitton, que es nuestra intérprete esta tarde. Thank you so much.
Great. Thank you so much, Marta. Thanks, Michelle. So I am going to turn this webinar over to Dr. Willis and Dr. Santora. But first, I just want to express my thanks on behalf of the entire community for both of you. I believe this might be their 150th communication that they've provided to our community in this last period of time. And I will say that when we think about why Marin's doing well, it's because of the two of you, your leadership, your passion, and your support for all of us in our school. So with that, Dr. Willis.
Thank you, Mary Jane. Thank you, community. I think it has been one of the elements of our success has been really the partnership across the board with the schools, public health, our schools, so the school committee and Office of Education, and parents and students. Next slide, please. This is our epidemic curve so far, and what shows is that I think since we last spoke a week ago, we have a new high, 625 cases reported on January 4th. That was our highest so far. We do see some evidence of potential plateauing, which I'll share with you in a bit. Our estimated point prevalence, and that's the epidemiologic term for the proportion of our total population that we estimate to be infected at the moment. Because of our widespread testing we did as a return to school initiative, 37,000 results within about a 3-day interval really offered us a very precise estimate of what's happening in the community as a whole. And it was about 4% positivity, which would mean that about 10,000 to 15,000 Marin County residents are currently infected with COVID-19, and over 99% with the Omicron. It's really virtually all Omicron currently. Next slide, please. And this is just to put that into context. Here represented on the left in July into August is our Delta surge. It felt like a dramatic surge in cases at that time because we went from near zero. We actually had a few days where we had no cases at all. And we went up to 80 cases a day for a few days. That was our Delta surge. Now we're looking at with the Omicron surge, which is about 300 plus cases now on average per day, with a peak of over 600. Next slide, please. Important to follow that though with some information about about severity. So stepping back, this is what I see as one of the key challenges for us at this current time. This week, last week, and next week are really critical moments for us to start changing our mindset, really understanding what will be the nature of this pandemic ongoing. And it's important for us to recognize that our policies and our mindset, our mental models for how we've been approaching this pandemic are based on the data and the true life experience of prior variants. And those variants were very different than Omicron. Every day we're learning more about this new variant. Those variants were more virulent in their nature. We had higher hospitalization rates, higher death rates, and especially in the pre-vaccine era, a lot of collective trauma for us as a community. We were experiencing 3 deaths per week for a while there last year before the vaccines arrived. 3 deaths per week. We're dealing with about 2 to 3 deaths total per month now. So very different. And those deaths are among unvaccinated people primarily. people who are older and have more serious medical conditions. We're also dealing with strains that are more infectious, less infectious in the past. So we saw fewer cases, more virulent, but fewer cases that were more easily controlled through our interventions. Omicron is so widespread now that our policies, if those policies are designed to prevent all infections, the policies themselves would actually tilt us towards more harm and could be damaging. And that's why we're in this process of trying to adjust our policies to match the threat that Omicron represents. Reducing risk of infection remains important to us. It's not time to just throw up our hands and say no more policies, although some people are advocating for that. They remain important, and it is possible to reduce risk of infection, especially in our most critical sectors like our schools. And that's what this conversation is about. Next slide, please. This is, to me, the most important single data point that I've been looking at, which is trying to estimate the consequence of being infected with Omicron. What is the severity of disease? What can we reliably predict as the threat of infection? And as each day passes, I think we're gaining more and more reassurance that it's really not driving severe illness. If you look on this graphic, it shows the blue line is our case rates. And you can see over previous surges, the yellow bars, which represent hospitalizations, really followed pretty closely that blue line. In other words, as case rates went up, so did hospitalizations. That relationship has changed dramatically with Omicron. You can see that dramatic increase in cases, but their hospitalization rate has not changed very much. And that's true now in Marin. We have about the same hospitalization rate this week as we had last week. And we'll be watching this very closely. Next slide, please. Sorry, the next slide, please. So that our public health goals, again, just to sort of ground us in fundamentally what are our most important priorities. It's to limit hospitalizations and deaths. That's always been our primary focus as a county. And then now with the number of cases, I think an equally important goal is to maintain critical societal services, infrastructure, maintain our workforce in our schools and childcare, hospitals and healthcare, our first responders, our ambulance crews, law enforcement, fire, and other essential sectors. Next slide, please. So what's our status regarding those particular priorities? For hospitalization deaths, we have about 12 to 15 patients in the hospital in Marin who are hospitalized for COVID-19. That is those people who, because of the infection with the virus, have been rendered ill enough that they actually need to come into the hospital for care. About 12 to 15 over the past 7 days, and that has not changed much. It's about the same today as it was a week ago, and I just checked in with the hospitals, and they're seeing more people who are admitted with COVID-19, that is people who are in for other reasons, and because the prevalence is so high for Omicron in the community, you might be in for at 9 months because you're ready to deliver your baby, and they do a test and it turns out you might be infected. So there are more asymptomatic people with COVID-19 in our hospitals, but those that are in the hospital because of COVID-19, it remains stable at about five per 100,000 residents. We've had one confirmed COVID death in the past 2 weeks, likely infected with the Omicron variant, but that was an older person who was at the end of life and was in hospice. Our schools remain stable thanks to your great work. And some hospitals and facilities are invoking crisis protocols for staffing that it even allows them to bring people who are actively infected but asymptomatic back into the line of duty as long as they're following certain protocols, especially facial covering with an N95 mask. Next slide, please. So this is a piece of, I think, good news, which is that we are starting to see evidence of a plateau in our Omicron surge. Our surge began around December 20th. It was really that inflection point. We had been seeing kind of an increase in Delta, and then it really took off with Omicron. It's now almost all Omicron, and we have not seen significant increases in cases over the past few days. So that's the first sign that we may be seeing a plateau. And then, as we predicted, that's about 3 weeks in the plateau, and then we would start hopefully seeing a decline by the end of January. Next slide, please. So here's our prognosis with regards to Omicron. Rapid increase started on December 20th. We may see a plateau this week or next. our cases, recognize our cases are probably undercounted because there are so many people who are not having symptoms or mild symptoms who don't even get tested, combined with the lack of access to testing, might undercount cases, but that's why another reason why I have to look at our hospitals most closely. We expect a manageable increase in hospitalizations. We may have a few deaths among our most frail or unvaccinated residents, but we do expect and are seeing significant stress in our workforce in all sectors. And we need to make sure that our policies that are designed to prevent infections don't paradoxically actually harm other essential services and are striking that balance, applying CDC protocols that themselves are being revised regularly. And we're expecting a decline by the end of January. Next slide, please. This was something I wanted to share with you. The Journal of American Medical Association, JAMA, it's kind of the primary medical journal that we look to, had an excellent editorial by some of the White House strategy advisors about what is necessary, what are the necessary elements for us to enter into the new normal life with COVID. And they mentioned 5 things. One is real-time information systems, so good surveillance. The other is having an adequate public health workforce to respond. So increasing our public health workforce. The other is allowing more flexibility within our health systems, so our hospitals and our clinics can actually be responsive when testing needs come up, when vaccination needs come up, and care for patients who are sick. And then the last 2, I think, are the most important. One is trust in government and public health institutions. And again, they're speaking from a national perspective and recognizing that the distrust has been such an important determinant of risk, especially in lower vaccinated communities. And then belief in the value of collective action for public good. Next slide, please. And it came up on our call last week in terms of what, if we did have any sort of elements of success in Marin, what are those? And I think obviously there's been a lot of hard work, a lot of operational strength, resources we brought to bear. But I think even behind that is what Mary Jane was alluding to first, is that there's been trust within our system, 360 degrees of trust across our school communities, with healthcare, with public health, with school administration and parents. And that's been critical to allow us to sort of develop that 32-point plan, follow that plan with vigilance across all of our schools and all school districts, and revise that plan from a point of view of humility and responsiveness as we learn more along the way. And then also importantly, this belief, the last element that was highlighted, a belief in the value of collective action for public good. And I just thought it was inspiring that would be included as one of the 5 most important elements of success in the new normal, is a belief in the value of collective action for public good, because that's a cultural factor. That's a matter of ideology and something that I think has been really strong for us. And I think we can all feel grateful to one another for having that responsiveness for us as a community as a whole throughout this pandemic, and will carry us into the next chapter. Next slide, please. So here we go. Students and staff are safer in school. All right. So this is something that we were actually able to share with the nation in terms of what we had learned in Marin. We were able to publish a paper that's titled there at the bottom, really showing our data after we put the 32-point plan in place. Remember, we were one of the first counties to sort of start approving those waivers in August of last year, where people were applying to be able to open. Our practice in public health was to approve waivers with a lot of support for the schools to actually implement those practices with vigilance within their own school. And we were able to show that actually community transmission rates dropped. When schools began to start opening and that fabric started sort of reknitting, we were able to see through that structure and the supervised safer environments in schools, that community transmission rates dropped and kids were actually safer in schools than out of school. And it was really kind of a revelation in terms of the thinking, because we had thought that bringing kids into school might be an acceptable compromise, but would lead to more cases, but it might be less harmful. And in fact, it was actually beneficial both for social and emotional reasons, academic reasons, but also for public health reasons in terms of transmission rates. And that's an important principle for us to keep in mind in this stage also, is that because we are seeing so many cases, we have to not make the mistake to assume that bringing children into school, students into school drives transmission. In fact, the opposite is true. So we saw a drop in countywide COVID-19 cases as we brought more people into school, and that was published and used nationally as a rationale for reopening schools in places where it was even more challenging to do so. Next slide, please. So what are our assets as a community? Obviously, the strong partnership between the Office of Education, Public Health, and you all are in our schools. We've been child-centered and equity-focused. I think another lesson for us has been really just keeping our eye on that, on the North Star, which has really been keeping, focusing on our students, focusing on our children, and focusing on equity. We've been data-driven. That's another, I think, asset for Marin. We have a great epidemiology team, and we have the opportunity to look at our own data and our own experience on a day-to-day basis and refine our strategies based on what the data is showing us about our own community, combined with literature from abroad. Responsive policies, obviously trying to be responsive at every moment. The community, the liaisons, the public health liaisons at the school level have been also critical. And then just from a biological standpoint, we have the asset of very high vaccination rates and booster rates, which is a layer of immunologic protection that cannot be underestimated as a benefit for us. And if there are new variants that emerge, and vaccines are an important part of protecting us against those next waves when they occur, we're in a really good place to have that protection, because we already have demonstrated that we can have high levels of vaccination very quickly, both because of the beliefs in the community and because of the operations that we as public health can offer the community. Next slide, please. So that concludes the background, and I'll hand it over to Dr. Lisa Santora for an update on where we are with our school policies. Thank you.
So we do have some significant updates from the last time we met together. I just wanted to have some entry slides. I know there's a lot of frustration and challenges when we have our guidance continues to change. And there's just a process to that it takes time. As you saw over the news during the holiday break, there was a lot of changes at the federal policy level and even the state policy level that we then need to interpret and adapt to our local conditions. So that is what drives us. We have to follow, we're under state orders still, and we have to align our practices with the state, but it is a process and it takes time for us to adapt these, our guidance to reflect the changes that we're seeing at the national and state level. And also they're still clarifying their guidance. When you saw the policy change at the federal level, the government was on vacation. And so there wasn't commensurate changes in their web pages and their instructional and educational materials around those policy changes. It took until January 8th for the CDC to update and really refine its guidance on isolation and quarantine. So that puts delays, and we appreciate the frustration and again, the challenges of managing those delays when you're frontline staff at the school level, and then when your parents trying to understand what's the process of getting your children back into school. Right now, the CDPH has not updated their guidance yet for the K through 12 schools as it relates to the changes that we've seen. So we're still working in an environment where we don't have all those updates. And as Dr. Willis said earlier, we want to be responsive to the needs of our school community. We want to walk that middle path where we're recognizing now that the harms of some of our policies may outweigh the benefits of controlling the disease transmission itself. And so we're navigating that. And we also do that in partnership with other Bay Area health officers. We are interconnected in the Bay Area. We have staff who live outside of the Bay Area. We have sports teams that play outside of Marin County. And when we make changes in our policy, it is shared widely in the Bay Area. So we want to make sure we are synced with local Bay Area health officers, as well as providing time to the state to provide updated guidance before we just jump and make our local interpretation. We can jump to the next slide. So we have a new update. This is new for this school year. Everyone in the school community will now have access to our isolation and quarantine guide. We are going to be updating our decision trees. If you go to the isolation and quarantine guide, it is accurate, but it is dense. And we know it takes time for people to navigate that. So our team now is working on more visually friendly decision trees that reflect the changes. We meet weekly with our public health liaisons, and we are so thankful to them. We know how hard you've been working and relentlessly trying to keep your schools open. And we've added a new weekly update that our schools team is preparing just to provide the highlights of what are the changes that have been made. And then our schools team has also added weekly office hours for policy questions. So really trying to increase access to our team in an efficient way as we're seeing more cases than we've ever seen before. Jump ahead. So these are some of the big updates that we believe will positively impact students and their well-being, but it is a change. So that's where we'll be available tomorrow. It's Thursday, so we'll have our public health liaison meeting and just to navigate some of the questions that may arise from this. So the Omicron has been circulating in our community probably since early December, if not in November. And as Dr. Willis said, we reached the peak. We started seeing real significant increases on December 20th. And that means with the numbers that you're seeing, a lot of unvaccinated students and unvaccinated persons have already been infected with Omicron. So for students who are unvaccinated and have had a recent infection in the past 30 days, they do not need to quarantine. They need to monitor for symptoms and test if they're symptomatic and isolate, obviously, if they test positive. We have not yet seen reinfection with Omicron, but it can happen. And so, but at this point, if there has been a known infection in the past 30 days, they do not need to quarantine if they're exposed. And that's a change. You can jump to the next slide. So this is a new group. And again, we think this will really positively impact our students' well-being and access to in-person instruction. We had major changes in policy happen over the weekend and major changes in access to booster vaccines that affected especially that 12 to 15-year-old group. So moving forward, fully vaccinated, unboosted students with a known exposure to COVID-19, until we receive further guidance from CDPH, can attend school and participate in extracurricular activities, including high-risk sports, on 3 conditions. They need to be asymptomatic, they need to test negative in 3 to 5 days after their last exposure, and they need to wear a well-fitted mask around others. So at this point, we are allowing this until we hear further guidance from CDPH, but we are strongly urging everyone to get their booster shot as soon as possible. So you can jump ahead. Testing priorities. We know testing is a challenge. I just introduced a new place where we need to have students have access to testing in order to prevent a quarantine. So that means we need to prioritize our testing because it is a scarce resource right now. So our top priority for testing is those who are symptomatic. Our second priority is high-risk known close contacts, including those sports contacts or known friends. We really see that we know how COVID moves in our community. It really moves through close contact, gatherings indoors when people aren't wearing their mask and they're eating and drinking together, not in the supervised environments of the school. For that reason, we're not recommending that we test after a classroom exposure. We were recommending that previously, unless it's a known close contact. Again, a known friend, a known carpool participant. We also recommend testing to exit isolation and quarantine. And again, that's to shorten those isolation and quarantine periods so we can have students back at school as quickly as possible. And we are not recommending that students test after the MLK break. Again, we don't want to burn through limited testing supplies. This is not, the MLK break is not typically a gathering time like Christmas and New Year's Eve. And there will be families that should test because they knowingly engage in high-risk activities like gatherings with multiple households, and they should have access. They should procure their own tests if they're going to engage in high-risk activities so they can make sure their students are tested before they return to school if they do engage in high-risk activities. So you can jump ahead. So after an exposure, and just reinforcing that, everyone should monitor for symptoms for 14 days. And remember, because we're vaccinated and boosted, we're seeing people have very mild symptoms. It might just be a headache or sore throat that people are attributing to a sinus. It feels like a sinus headache. Test if it feels like a sinus headache. Again, we're only recommending those high-risk close contacts. Test on day 5. The exposure outside of school is the higher risk than the exposure in school. And so if there is a known exposure due to a peer group, those students should test. And again, test if you become symptomatic, especially if you have mild symptoms. Jump ahead to the next slide. Exposure notices. We know that this has been a major issue. Parents and schools are sending out exposure notices, and you're receiving exposure notices all week. We now know, as Dr. Willis shared, that there's a 4% prevalence in our community. That means 4 out of every 100 people right now probably have an active case of COVID-19. They may be asymptomatic or more mildly symptomatic. It wouldn't be noticeable through sneezing and coughing like the previous variants. So we're no longer recommending that we send exposure notices for positive cases in the classroom. We expect that schools should identify and notify those known high risk or close contacts. Again, those known peers or those known friend groups should be notified as a close contact. We need to quarantine the unvaccinated. Everyone else should monitor for symptoms, and those known high risk close contacts should get tested between 3 to 5 days after the last exposure. Everyone in the school community right now, everyone should be monitoring for symptoms. Everyone should be staying home if symptomatic and test. If you have a positive case in your household and someone else develops symptoms, you don't have access to testing, it is presumptive for Omicron or COVID. It is very highly transmissible. In our vaccinated population, the attack rate is 100% if you're exposed. So if someone in your house has COVID-19, it's most likely Omicron. If you're just fully vaccinated, you're probably 100% assured that you're going to get infected, even if you're asymptomatic, which is why we recommend that you test. And then if you're boosted, we see the attack rate around 50%. So it's still a 50-50 chance. Wearing masks remains very, very protective. It reduces that attack rate almost to 20%. So again, everyone should consider themselves exposed to COVID-19 unless they're not seeing others. So jump to the next slide. And this is just a reminder of our isolation. So day 0 starts at the day of a positive test or the start of symptoms. Remember, people start symptoms because of their immune response. It's not a reflection of infectivity. And the symptoms may be delayed after you've been infectious because you've been vaccinated or boosted. So that's why day 0 is either the day of a positive test if asymptomatic or the start of symptoms. Assuming that if they're starting symptoms, they probably were infectious a day or two prior to the start of symptoms. Then you need to remain home for a full 5 days. And on day 6, you can return to school if you have a negative test. It's really important. A positive is a positive. We do not need to confirm with a PCR anymore. There's so much Omicron circulating that something we call the pre-test probability is very high. So there's not a need for a confirmatory PCR. You may repeat if testing is available on day 7, and if negative and without a fever, you can return to school on day 8. If positive on day 7, at this point, with our state guidance, you're going to stay in isolation through day 10 and return to school on day 11. There's no testing required, and we're not recommending testing to return to school at all, except for the shortened isolation period. We know many people have multiple test results. Public health can't manage multiple test results and saying which one is a true positive. Any positive is a true positive. Students and staff should go to their healthcare providers if they need information around a negative test and a positive test. But in our opinion, any positive test is a positive test.
Can I just piggyback on that, Lisa? So just speaking on behalf of for our hospitals, they're seeing that there's a big demand in PCR testing. And there's obviously been a huge surge in the demand for PCR testing. This is the laboratory-based testing where you go to a site, have the swab, and then have it sent off and get a result. The turnaround times now are on average about 3 days for PCR testing across Kaiser, Marin Health, all of the testing sites. And that's just based on volume. The laboratory machinery just takes a certain amount of time to process each sample. When you have so many samples, just the turnaround times increase. So we were never recommending that people try and seek confirmation for PCR with the rapid antigen. Go with the positive as a positive. But now more than ever, it's inappropriate to try and sort of test out of a positive rapid antigen results, because you're not going to get the result for another 3 days at best anyway. And you're taking a test from someone who might need it for testing for symptoms. And especially, and I wouldn't imagine anyone on this call would be doing, but we are seeing that some people are actually going to emergency departments just to get tested. And our ERs really just need to be reserved for, obviously, for people who are in there for medical emergencies and not people seeking COVID-19 testing. So just a public message there. They put up signage, but it does interfere with their ability to manage medical emergencies in emergency departments when people are coming there for testing.
And we know it's very frustrating that people are having a hard time to access testing. So if you can access a test and your student is developing symptoms, what we would recommend, they have symptoms, they wake up and they have a sore throat, you don't have a COVID test, notify the school, keep your student home and say they have symptoms of COVID-19. This starts your count. So now you'll have 5 days to secure a test, to test after day 5, and to test, and we would call this is a presumptive Omicron or presumptive COVID infection. You've notified the school at day 0. I'd say we don't have access to tests, but symptoms have started. You're starting your isolation period. You secure, I hope our team can put in the Find a Test app, which seems to be working for many people. It tells you Walmart or Amazon where there's available home-based test kits that you can access in the next 5 days. If you can't access that day, test after day 5. Best chance of getting a negative test is testing on the morning of day 6 before your student goes to school. Just gives a longer time for the antigens to wash out. And if you have a negative antigen test on day 6, then your student returns to school. So that's the best use of scarce resources. Notify the school right away if your student has symptoms. We can start our count right there, then test on day 6 before they return to school. You've washed out those antigens, and that will minimize the time out of school at this point with this testing protocol. Jump ahead. That's what I would do. We really are recommending rapid antigen. We do not recommend a PCR. If you remember a term called dead shedders, you can have a PCR positive for a very long time. So it really is the rapid antigen test that you should use. If you go and get a molecular test or PCR test, you're running the risk of having a positive because it's still detecting the virus in your system. So it is the rapid antigen test that we strongly recommend using to exit isolation and quarantine. Jump ahead. Do staff and students need to wear a mask? Absolutely. As I mentioned, we saw locally with our own data how protective masking is. We also now have meta-analyses. That's when researchers bring a lot of different studies together to analyze what public health mitigation strategies are effective. And in a study of, I think, over 72 studies were pooled, and there were, I think for the mask, they had 7 studies that evaluated the effectiveness of masks. It reduced the risk of COVID transmission by 50%, which is consistent with what we saw in our farm shop outbreak locally, where we had boosted individuals had that attack rate of 50%, and people who were wearing a mask had an attack rate of 20%. So masks proved to continue to be an effective tool. Do your best with our younger kids, but make sure that they have mask breaks during the day. That's going to make it easier for them. We are recommending that when kids are gathered and don't have any distancing, that they do wear the mask outdoors, but obviously when they're eating or drinking. And so the 2 things that were proven to be effective in that meta-analysis of public health measures was masking and physical distancing. So being more than 6 feet away from each other. So those are 2 effective tools that we can continue to optimize as we navigate these next couple of weeks with Omicron. Jump to the next slide. Boosters, as much as there is policy changes around isolation and quarantine, there is good news in increased access to boosters. Just remember some of the changes that happened over the holiday was that the CDC stood firm in its recommendation for the mRNA vaccine as being preferred. Previously, there was just consumer choice, but now it is really recommended that you have an mRNA vaccine. They have updated that everyone over 12 should get a booster. And again, remember, it's only Pfizer for the 12 to 17-year-olds. They shifted when you can get the booster. They dropped it from 6 months to 5 months. Also, they added the 4th dose. So immunocompromised persons, after they receive their primary series, and if someone is moderately or severely immunocompromised, it takes 3 shots to complete their primary series. They then can get their booster shot 5 months after that initial series. And then they also added that children, 5 to 11-year-olds, can receive an additional primary dose if they're moderately or severely immunocompromised. So again, this is an important tool that we didn't have last year. Is just expanded access to boosters, including for children who are immunocompromised. Jump ahead. So get boosted today. We do have available booster appointments. We had 1,500 booster appointments that were available last week that weren't unused. So, and we know that that's going to go down as the new populations are invited to join eligibility groups, but our website is the best place to find available appointments. We really are appreciative of our partnership with Safeway, who's been a tremendous partner in offering vaccines at our Northgate site. And we're working diligently with our healthcare providers. Ideally, every single healthcare provider in our community is offering the vaccine, especially for the younger age groups where parents and guardians can be able to have a conversation with their provider. We've reached our goal of boosting the 55+ population, and I'm really proud. We didn't hit our goal. We aimed for 75% of children to have their first shot of the vaccine 1 month after it became allowable, and we hit 72%. And again, that just offers that protection that Dr. Willis was talking about earlier in our presentation. You can jump ahead. And they're newly vaccinated, so they have good, strong immune response. And I just wanted to provide an update on our dashboard. I think part of the trust that we have built in the community is, one, our access, having these regular conversations with the school community. 2, we really strive to respond to emails and communications from the public. And 3, we've been sharing data. So that being said, we have so many cases of Omicron that our ability to pinpoint whether it's a school-based transmission is no longer possible. And also just trying to count the number of cases that are related to the school community has become really challenging. So we're going to be updating our school dashboard and removing the cumulative positives. We may still report the number of positive cases by age, but it's not going to be directly connected to the schools like it was before. There's just such high number of reporting, and it's hard to keep up with the number of cases, honestly, right now. But we will be adding the county vaccination rates for the 5 to 12-year-olds, the booster rates for the 16 to 17-year-olds, and then the 12 to 15-year-olds. And we'll be adding the number of home-based test kits that we've distributed. That's one of our biggest successes in December, was the ability to distribute tens of thousands of test kits, so we can make sure students didn't come back to school infected with an active infection of COVID-19. And we'll be working again to distribute more test kits at the same levels. And I just want to thank our partnerships with Marin Community Clinics and the Ritter Center. They've been working to draw down additional resources from the federal government, not only for their patients, but they're sharing those resources with the community. So there's many other communities, school communities, that have not had access to these home-based rapid antigen tests. And it's because of our partnerships across the community and with the healthcare sector that we've been able to ensure access to these home-based antigen kits for our school community. And we'll keep trying to get more testing available in the community. I think that's the last slide.
Can I just say one more thing about the home-based rapid tests? So we're trying to get as many tests as we can down into the community, which means that we'll take whatever is in, it's as long as it's emergency use authorized and a quality test, that's the product we'll use. So we're starting with Binax, and then we went to the iHealth. Now we've got CareStart. So you might be receiving a product that's unfamiliar. So, as we move through, we'll continue to distribute what we have access to, just signaling that there may be another product coming your way. You just have to make sure that we're clear on the instructions as each one comes out, because the performance on those tests, as you do them at home, is critical for the accuracy of the results. And ideally, we'd have the same product each time. We just don't have the luxury of that right now.
Okay, you ready for questions? All right, so there's a lot of different questions in the chat, so I'm going to try to ask a few general. Can you talk about whether or not we know about Omicron related to long COVID? Any questions or anything you can say about long COVID, people's concerns about it, the implications of it, and is there anything Omicron related to long COVID early data?
We really don't have enough under our belt yet in terms of timing for long COVID for Omicron. We do know that vaccinations do reduce the risk of long COVID, and that's kind of the most important asset for us is very high vaccination rates. We know that Omicron generally causes less severe illness. It stimulates the immune system in different ways. Many of the consequences of long COVID syndrome relate to kind of the deep immunologic response from the more severe variants that had emerged first. With Omicron, it is more like the cold. We know that it has actually mutations that are more cold-like in their nature, which is why the symptoms are more cold-like in terms of sore throat. We're seeing more of that, less high fever, less respiratory distress. So you could hypothesize that would correlate to a reduced risk for long COVID. But I think the more important asset for us is our high vaccination rates for protecting against that.
Okay. Is there a reason that you're not requiring masks outside given this surge for schools?
We are recommending masks outside for settings where children are not able to manage social distancing. We are recommending masks outdoors.
How does recovery from a recent infection play into isolation and quarantine guidance, especially when it comes to an unvaccinated children? I think you've already covered that. Next question, what are you doing to support the mental health of teachers and school staff? I'll take that. The second to last week in December, we had a wellness week that was available to all of our teachers and staff. They provided 15-minute increments 3 times during the day of strategies to use that would be supportive and helpful for all of us to take good care. That was very successful. We had about 1,000 people from throughout the county participate, and we're planning on doing that again. That's one example that we were involved in countywide, which included our partners, of course, public health, as well as Kaiser Permanente, but want you to know that there are a myriad of other activities that are going on in the community and school-based that are looking at various strategies. I think the main thing for all of us to know is that each of us will need to hold responsibility for our own health and our own mental health. And so if we can take advantage of these opportunities that come forward that will put tools in our tool belt, that can make all the difference. Anyone who's interested in what happened during that week, it's online and available. So you'd be able to partake, even though it wouldn't be in real time. Why are you implementing the illegal policy of not allowing unvaccinated parents on an indoor sports game?
This is a recommendation. So we are not ordering. We know a lot about Omicron and its behavior and how contagious it is. And we see the very high differential between the case rate in our unvaccinated population and our vaccinated population. And our goal is to cocoon the in-person educational experience for our students. We don't want to close any of our schools. We want every student to be able to attend school throughout the Omicron surge. And that means protecting that school environment. One of the highest risk activities we've seen throughout Omicron has been indoor sports activities that drives infections. And so one way to do that is doing what we know reduces the risk of COVID-19 transmission. So the first is reducing the number of people in any particular gathering. And so we are capping that. We are recommending a cap of that of 50. We know that unvaccinated persons are much more likely right now to be infected with Omicron. So we're recommending limiting attendance to those who are vaccinated and if booster eligible boosted. And we're recommending that everyone wear masks, which we know did not happen over the winter holidays, especially in a lot of our sporting events. So sports are an important part of our students' well-being and their development, and we truly value sports. We have children in sports, but for these next couple of weeks, these are short-term mitigation strategies that are intended to cocoon the in-person educational experience and to keep our schools open and to reduce the risk of transmission.
AJ, can I just offer a data point on that? I think a lot of these questions that are so fraught, and then now further clouded by sort of the political landscape. I think the best way to approach it is just to start with the data. So we're all looking at the same thing, and then we make meaning of it. Unvaccinated people in Marin County are 10 times more likely to be infected than vaccinated people. That's just a fact. That's the numbers, because we have the vaccine status on every single case. Because when someone is vaccinated, it goes into the registry. If someone is a case, it goes in the registry. We cross-reference those lists. 10 times higher risk of being infected if you're unvaccinated.
Okay, this is a question that has been translated from Spanish, and I'm not sure what agency, but Matt, or at least you might be able to help. What help can be given to a parent when everyone in the family has COVID, the family doesn't have money to pay their rent? Where could they go? Is there an agency that they could go to get some support?
Would be that community response teams, Lisa?
Yeah, so it depends where in the community that people live. We have partnerships with community response teams across the county. We will develop a communication to help people know and identify and access those resources. Those resources are limited, and we're working in partnership with the Marin Community Foundation to expand those resources. At a previous point in the pandemic, we had resources like rental assistance and food resources that we no longer have anymore. So we hear the need, and we'll work on improving communication. So regardless of where you live in Marin County, you'll know which resources you have access to.
When are we going to get back to better hand washing strategies?
People hate washing their hands. Hand washing, this has been very well studied in healthcare. Hand washing is one of the most important strategies for reducing the risk of any infectious disease transmission. It can reduce it by upwards of 50%, because most times we are getting infected because we touch someone, hug someone that may have any respiratory droplets, and then we rub our nose and touch our face. And so hand washing regularly is one of the best tools we have. It's the one humans least like to do. Probably less, they're more willing to wear a mask, honestly, more consistently than wash their hands with the frequency that would reduce the risk of infection. Since the beginning, we've always have been urging people to follow those ABCs of staying home when sick, wash your hands, wear a mask. If you're not good at washing your hands, make sure you have hand gel everywhere. Even that, once we shifted out of the shelter in place mode, we saw people's hand washing behaviors decrease significantly, but it is effective.
Yeah, and thanks for that question. I want to that's for the future. So I think what we learned about the COVID-19 or SARS-CoV-2 really was more on the spectrum of aerosol and respiratory, but all the other stuff that dogs us every year, flu, RSV, adenovirus, those things that cause colds and other significant actually stress to our healthcare system, that especially influenza, hand washing, super important. So that's, if we can take a silver lining out of this, or whatever we've learned from this experience with COVID to kind of protect us ongoing, that's one of the lessons for sure, is upping our game around hand washing, and maybe even face covering in selective settings, even after the pandemic has passed.
Should my students stay home even if they have a mild headache?
Yes, they should stay home, and they should get tested for COVID-19. This is one of the common symptoms we are hearing that is being under tested. And then what happens is the headache continues for another day, and then people are testing, and that's when they're testing positive. So absolutely, a headache and itchy throat. This is an upper respiratory infection more than the lower cough, shortness of breath respiratory infection. So those mild symptoms, you should stay home. My school had an experience where the teacher surveyed all the kids today and asked who had a headache and a sore throat, and
they all did.
Parents got a phone call to pick up their kids because they're sending their kids to school with these mild symptoms. So parents, the first expectation of parents is keeping your kids home when sick, unless you have a COVID test and you can test and prove that they do not have COVID-19.
can you review this, the issue of the parents getting 3 notices at home every day? And what is the current recommendation now about how the schools notify parents?
So we are recommending that schools no longer send exposure notices. In the beginning, we recommended, because it comes back to trust. People were concerned that they weren't being notified about COVID activity in their school. Their student wasn't in the classroom, and it created fear and anxiety when they didn't learn about COVID activity. You can assume now that there is COVID activity at your school level, at your grade level, and probably at your classroom level. And so at this point, this is public health's official exposure notice for the entire community. Our schools team is working on language and a letter that schools will be sharing with parents and guardians around basically this is an exposure notice for the next month that we're all at potential exposure to COVID-19. We do expect that those true known close contacts who are high-risk close contacts as they participated in sports or performing arts or carpool together, the schools should be providing specific notification to those students. But everyone else, this is your official exposure notice that Omicron is circulating in your school.
Okay, so several people are concerned about not having specific data like we had on the dashboard. So Mike or Melina, could you pull up the data we do have so we can at least share that we are collecting some data to provide to the community. And while you're doing that, I'm not sure who would want to take this, Lisa or Matt. What are you, here, let's just do this real quick. Okay, so number one, this is the information that Dr. Santor and Dr. Willis noted, that we have close to 200,000 tests that have been distributed. Those are individual tests, 89,000 boxes of 2. In spite of that, we are very concerned about the supply. So you'll see your school district starting to split the tests. So issuing again, potentially 1 test as opposed to 2. And then as a reminder, the reason we find ourselves where we are is that we were essentially a pilot for the state in the fall. And we had early adopter schools. That was phase 1, phase 2. Phase 3, but you get a sense here that, and we're hoping for, just so you know, phase 5, phase 6, right? They'll have more supply to be provided, but this is what's special about this is that in other places that weren't part of the initial pilot, it did not include private independent parochial or staff. And so because of the leadership of our public health team, we find ourselves in a situation that's better off than others. And that next slide is going to show you what our data shows. So during phase 1 and 2, we distributed 17,000, about 18,000 tests total. And if you recall, these tests were to be only for people with symptoms, right? So this was the number that we had, 4,178, 32 positive. So we were at under 1%. And at this point, at the return to school, we issued the 93,000. We had 93,000 tests out there, and we had 37 tests reported. And so that is amazing, just for you to know. So thank you to the community for taking those tests and reporting. And our results then were at about 3.6%. So as you hear the information about things are very different than what we had seen prior to Omicron. Here's the data to show that. Earlier today, I was in a conversation with some colleagues, and this was the question. Dr. Willis, what do you know? What can you tell us as we're planning about what we should be planning for March, April, May? Is there another one coming? Do we get to and we know that, obviously things can happen, but what's your thinking as we plan forward?
Well, I think we're seeing, positive signs that the Omicron wave will be resolving in the next, few weeks, even as early as, potentially plateauing this week and next week. And that confidence comes from looking abroad to see, what happened in England and New York, and when our peak started. It's probably because the reason that the shape of that curve is determined by the susceptible population. So we're fortunate that I have a highly vaccinated population. It moves through people who are susceptible, and then it begins to subside. that will leave us all better off immunologically because we have the protection of the vaccines and then the boosters. And then it's hard won, but it is another form of immunity that when the virus moves through and has such a high attack rate across the community, you know, probably at least 10 to 20% of us will come out of Omicron having been infected, even just with this in the last couple of weeks. So that's going to also leave us better off. We suspect that there will be, unfortunately, what Omicron I think has also taught us is that this virus has the ability to mutate way more than people thought. I think science was surprised at how many different mutations could be collected on the same SARS-CoV-2. And that probably is a sign that we have more variants ahead of us in the future. That's the bad news. The good news is that with each wave, we're better off immunologically. It's likely to evolve towards more and more benign strains as this one demonstrates. So this is part of that process of going from pandemic to endemic relationship with the virus, like SARS-CoV-2, the way we have historically with other viruses that are now normal parts of our environment, including influenza. So I would expect that we will have another wave of another SARS-CoV-2 virus, but we will be approaching it very differently. The lessons learned, I think, from Omicron is going to be that this notion of rapid identification and isolation and quarantine of cases is outdated. We are not going to be approaching it that way. It'll be approached much more like other viruses, that we see every day, like influenza. That's kind of the general prognosis, and I think that's the consensus among most in the public health community. That is likely our future. So we should expect to have more variants, but we wouldn't expect to have to develop the same sorts of infrastructure or drop everything kind of response that we've had to this waves that we've experienced thus far. We also need to be humble about this. Another thing we've learned is that it's really difficult to predict. And the general principle is that we need to stay connected, stay responsive, be transparent in our process, and move together when we need to move.
I just want to add that we would expect to see some simplification. Right now, California is exceptional. It took a more conservative tact by including testing to end isolation and quarantine. That is, I believe, we're the only state, maybe Hawaii is requiring that. And the rest of the country is not, and that's based on science. It's not a decision. And California's exception has in the past protected us. If you look at almost every measure nationally, from vaccination rates, booster rates, sheltering down in place and avoiding the spring 2020 surge that we saw in New York City and affect the East Coast has been very protective. And I think where we are moving is into alignment with the state and the NCDC. And you have seen, if you've been tracking, we don't have the same level of local orders that we had before or regional orders, because we're moving towards a simplification where, again, as Dr. Willis says, it becomes like the flu. This is one of the few infectious disease right now that you have to test negative to come back into a school environment. And I would not anticipate that being the case at the start of the new school year. With humility, knowing that things do change and we need to follow the science and being adaptive to that.
Okay, on those positive notes about what the future will hold, just to remind everybody that we'll have another session like this available to the school community on February 9th. But as you know, if something comes up that we think it's important to have another one earlier, we will. So, but for now, it's scheduled for February 9th with our labor leaders on February 7th. And then just so everyone is reminded that the public health liaisons meet every single Thursday, and they're constantly getting the most up-to-date information. So with that, happy Wednesday afternoon. Everybody be safe, wear your mask, and don't forget to wash your hands.